Hi, I'm Dr. David Sundy, and I practice in San Francisco, and I specialize at treating knee injuries, especially meniscus tears, where I have about a 100% success rate. I began practicing in 2001 as a massage therapist, and chiropractors started sending me knee patients because I was trained in Hendrickson Method, which has some very specific techniques to helping knee injuries, and I started having really good results. I went on to learn about 30 different techniques and graduated chiropractic school in 2010 at Life West in Hayward. Right now I'm co-authoring a book in non-spine related disorders with other chiropractors. Other notable achievements are when I was in school, I adjusted and helped the head of the adjusting department, the head of the biomechanics department, and the meanest doctor in the health center. They all had severe knee injuries. The first one was scheduled for double knee replacement surgery. The second one told me he had no cartilage in his knees, no ACLs. He walked with canes in both hands. And the third one was in a wheelchair. He tore through most of the structures in his knee in a sporting accident. The first one, with the double knee replacement surgery, he was able to cancel his surgery after I treated him 3 times. The second one, walking with 2 canes, he's now able to walk up the stairs with his bike on his shoulder and bike to work. And the third one told me if I could fix his knee that he would buy me a car. So he bought me a Matchbox car, which is kind of sad.
That's what you had in mind.
Not what I had in mind, but yeah. So basically, I do longer office visits that are about an hour in duration, combining any of these 30 different techniques. For this particular case study and for my current methodology, I combine Hendrickson Method soft tissue work, Activator Methods, motion palpation and functional motion assessments, laser therapy, all in a framework of SOT, making sure to clear cranial patterns and SOT categories. So I'm going to get into, currently the standard of care is actually conservative management with an MRI. So they're moving away from surgery because they know that these meniscectomies accelerate joint degeneration, and the MRI is really necessary for the doctor to know, because when you have a root tear or a radial tear within 1 centimeter of the root, it completely destabilizes the cushioning capabilities of the meniscus, and it basically renders the meniscus as if it's the same as it weren't there, or if they had a meniscectomy, and they also get accelerated joint degeneration. So we need an MRI, and we are the best people to work on these. The structure of the meniscus is a fibrocartilage pad, and it actually has tons of functions. They previously believed that it was a vestigial remnant of a muscle no longer needed in the knee, and now it's known to be involved in shock absorption and weight distribution via increasing surface area, joint lubrication, proprioception, and providing nutrition to the articular cartilage. And it heals actually really well when you improve the motion of the area and you introduce corrective motion. The fibers are laid down from root to root in a semicircular fashion, and fibers in the body are stimulated to heal by friction, which was first developed or brought to our attention by Dr. James Creax, an orthopedist from England. When fibers are frictioned, they release more of the stuff that makes the fibers, but we need to have an absence of inflammation so the stuff can solidify into a functional fiber, and we need to have normalized motion so that we don't continue to destroy the structure, and we can roll that stuff into functional fibers. If we compare the cost of the average meniscectomy, $10,000 to $30,000, to my methodology, most people get better in 2 to 24 office visits, and they have a near 100% success rate, and all structures are retained. So it's a huge cost savings, and to be able to retain all their structures allows them to return to their full function. My patients return to skiing and tennis and dancing. Some changes to care that I found out about while performing my research, there's about 45 citations in this particular case study. Arthroscopic debridement is no longer considered to be of any benefit in the treatment of degenerative type meniscus tears. So if your patients are asking, should I get debridement? The answer is an emphatic no. The Thessalay test, which has been used for a little while now, it's where the patient bends their knee and they rotate on that knee. It's unfortunately been found to be no longer of any value. It's really not, it doesn't show any consistent results. consistent with arthroscopy and MRI. And reattachment surgeries fail. And so some people want to know, should they exercise or not in order to recover from their meniscus tear? Most of my patients, all they need to do are knee circles once they're able to, and I have them practice 10 knee circles in one direction and 10 knee circles in the other direction 1 time per hour. If you need additional physical therapy exercises, I would say look to Dr. Mark Look's article, which is referenced in my paper, and he lays out all of the necessary exercises that a chiropractor would want to incorporate into their meniscus tear rehabilitation program. My particular case study is on a 35-year-old male who is in excellent health with a history of a lot of physical traumas, which most likely contributed to altered biomechanics, making him susceptible to knee injury. He came into my office with a confirmed MRI tear, and he had failed seeing another chiropractor, an acupuncturist, a rolfer, and his orthopedist recommended surgery, but frightened him, letting him know he's going to have accelerated joint degeneration and that joint would have to be replaced, and since he was so young, would most likely have to be replaced again. He came in with all of the exam signs that you would find in someone with a meniscus tear: a really swollen knee, weak leg muscles, muscle imbalances, knee pain and instability, fascial restrictions, inability to fully strengthen or fully extend his knee. And then his orthopedic tests, he had his positive McMurray test and joint line tenderness and an anterior drawer and Slocum's test. So we knew that the joint capsule got yanked a little, most likely where the meniscus ties down to the tibial plateau has gotten yanked a little bit. And ipsilateral hip flexion deficit, which is super important because if one of your hamstrings becomes super tight, then when you're doing a sporting activity and you have to bend on that leg, making it tighter, and then twist, it's pretty much like pulling a ripe fruit from a tree. So for this particular patient, I had him come in 1 time a week for 12 weeks initially. And I treated him very specifically for each of his different diagnoses. So for the meniscus tear with reduced range of motion, I did a figure 8 mobilization laid out in the Hendrickson book and some muscle energy technique to get almost all of his range of motion back. The rest, you have to get the swelling out first before you're going to get all of the flexion or extension back. And for that, you want to use a laser and use 1,000 to 3,000 hertz. You have to tap the lymph nodes in this area, the lymph nodes behind the knee, and sweep up. That's the current international protocol. And then to clear up various muscle weaknesses and to fix leg length inequalities, activator methods, and Sacro-Occipital Technique categories. My patient reported pain. I collected numbers at each office visit on a 0 to 10 scale, multiplied those by 10 to show them next to the percent frequency, and I saw a continuous improvement. I had to do another 12 weeks after the initial 12 weeks. So I saw a continual improvement over the course of the 12-week plan, where his exacerbations were directly related to overexertion during times of decreased pain. So it's really important to let these people know once you get them out of pain that the structures, the ligamentous structures, are not healed yet. It takes time with corrected motion and knee circles to stimulate the fibers to thicken to be able to support the area. His instability improved linearly over time. And I also collected standardized questionnaire questions on him as well, which all improved thousands of % for each of the different categories: pain and stiffness, daily function, quality of life. They're really, really substantial. This person went from no function, terrible quality of life, no quality of life, to back to running alongside his daughter, coaching her soccer practice. The clinical pearls, which I really like to share with you guys, from my experience, is that you need to get the MRI to rule out root tears and radial tears. The figure 8 mobilization is really beneficial. The patient's lying on their back, hip and knee at 90 degrees, and you're doing figure 8s, larger and then progressively smaller ones, to wiggle the structures back to the midline inside the knee. The extremity technique from SOT is great, with the foot sliding for when they have impingement and it's pinching on one side or the other. Activator Methods is phenomenal for getting the specificity of what's causing joint and muscle asymmetries and muscle weaknesses. For me, I love to cross-fiber friction anywhere that I think there's micro tears in the tissues. It gets that area to start healing faster, and it also clears up reflex weakness patterns in the muscles. And then lasering, clear up the SOT categories, and knee circles, knee circles, knee circles. The more they do them, the people that do them, they always get better. Currently, there's only 3 other people that have published on meniscus tears in our practice, so if you have cases, please publish. And where do we go from here? I'd really like to bring my methodology into the mainstream, so I'm going to look to Dr. Cooperstein and a local educational institution to help create something where we can really prove the safety and efficacy of this methodology, and potentially making use of wearable goniometers and accelerometers, this new technology, to really validate the improvements that are happening over time. Thank you very much for listening.
What are knee circles, and does the technique work on knee replacement or post-surgical repair?
What was the second part of the question? I heard knee replacement and then
Post-surgical repair.
post-surgical repair. Okay, let me show knee circles first. I'll stand on a chair. Feet touching, knees touching, shoulders over the hips, hips over the knees. First, the patient would, this is like right after they had, as soon as you restore enough range of motion and they can make this motion and enough of the swelling is down and they're not too unstable, the knees go out to one side and then to the bottom of the squat, and then they go to the other side of the circle and come up. If they have legs that bow out a lot, then they have to go into a slightly deeper squat and not come up so far that their knees come apart. And again, the small circle while performing a squat. 10 in one direction, 10 in the other direction. Gradually increasing the number of these that they do throughout their care plan until they're basically doing hundreds per day throughout the day. They really need to be smooth and gentle. The idea is to pull the structure back to the midline of the knee joint and to provide friction to the fibers of the meniscus to stimulate it to heal. As they're progressing further, they can do deeper, larger circles. The important thing is that it doesn't kick up any pain. It doesn't exacerbate their condition. Avoiding motion in the hips and shoulders, isolating the motion at the knee joint and the ankle joint. The circle's happening at the ankle joint. The knees are just moving out of the way and then back to the midline. Second part of the question, knee replacement. It's going to most likely be contraindicated. It's turned into a hinge joint at that point. They're not going to want to do knee circles. And the third part of the question, so say they had reattachment of the root or a suturing of the meniscus back together, it would be really important to get them to a safe place in terms of their stability, and then send them into the surgeon for surgery, and then have them come back for post-surgical care, and then continue again with the knee circles. If they're going to do knee circles and they're not balanced out and they have a short, tight hamstring, the hamstring has fascia that's continuous with the meniscus that helps maintain its proper motion when the knee bends. If they really have reduced flexion and they do knee circles, then they're just going to be making a repetitive strain injury when they do it. So they really need to have equal hip flexion on both sides and to be cleared out from head to toe as much as possible with their over biomechanics, so that when they do their knee circles, it's a rehabilitative and beneficial practice to stimulate those fibers, to release the stuff to become new fibers, and roll that stuff back into a functional fiber that can thicken and support the joint.
Dr. Sundy, regarding that, if there's enough meniscal tear that's like a joint mouse or whatever that locks it, you can still use this with that? Or
For the situation where they're going to have joint impingement, you can teach them how to do the SOT procedure at home with the gapping of the joint and sliding the foot. And also, which can be sometimes helpful for people with point tenderness or locking, knee circles can be used as a method to pull it out of place. Also, sometimes the tibia and femur get a little rotation in them, so they can kick the leg with the ankle flexed, and that can take the rotation out there. Then they can kick the leg, and if it feels like it's too tight on one side versus the other, usually that's a problem at the pubic bone level, and they can press their knees together. They can either put their elbows between them if they can bend that far, or just their hands, and go back and forth with squeezing and pressing apart, and then that makes a pop happen at the pubic bone and opens up a significant amount of hip flexion. Then they can do knee circles again and pull the structures back into place.